Hi everyone, my name is Liang Chen. I am a medical student from Tsuchi University and the creator of this video. I would like to sincerely thank Henry L. Lu MD, PhD, and Po Wei Chen MD for their guidance and support. The topic of this video is lower back pain anatomy and clinical exam. Low back pain is highly prevalent. Since the majority of cases are non-specific, the goal of the clinical examination is to rule out serious underlying conditions. In this video, we will start with the anatomy of the lumbar spine, introduce relevant diseases, and then guide you through how to perform a proper clinical examination. The lumbar spine, composed of 5 vertebrae, connects the thoracic spine to the sacrum. It is designed to bear the weight of the upper body while allowing limited but essential movements. Between each vertebra are intervertebral discs, which act as shock absorbers, and facet joints, or zygapophyseal joints, which help guide motion and provide stability. In the lumbar spine, these facet joints are mainly oriented in the sagittal plane, allowing flexion and extension, but limiting rotation and side bending. The spinal cord usually ends around the L1-L2 level, tapering into the conus medullaris. Below this, the dura mater, the tough outer covering of the spinal cord, continues downward and surrounds the cauda equina, a bundle of lower lumbar and sacral nerve roots that travel through the spinal canal before exiting at their respective levels. Each lumbar nerve root exits just below its corresponding vertebra. For example, the L1 nerve root comes out below the L1 vertebra, passing through the intervertebral foramen. These nerve roots go on to form part of the lumbosacral plexus, which innervates the lower limbs and pelvic structures. To better understand and manage lower back pain, it's helpful to look at it through a structured lens. We'll divide the causes into 2 main groups, mechanical and non-mechanical causes. Let's start with mechanical causes, which are the most common. Non-specific low back pain is the most common type, accounting for approximately 85% of all low back pain cases. It usually doesn't have a clearly identifiable cause and can be related to mechanical and psychosocial factors. Contributing factors may include leg length discrepancy, spondylosis, scoliosis, muscle strain, or ligament injuries. Treatment usually starts with non-drug approaches such as exercise, physical therapy, acupuncture, massage, or ergonomic correction. If the pain continues, medications like NSAIDs or muscle relaxants can help relieve discomfort and improve movement. Next, we have disc-related problems. Spinal flexion, such as when sitting, bending forward, or lifting, typically pushes the disc material posteriorly toward the spinal canal. When lying flat, intradiscal pressure is at its lowest. However, as the person moves to a standing position, gravity compresses the disc and increases intradiscal pressure. When the spine is flexed, such as during sitting, bending forward, or lifting, the pressure shifts posteriorly, pushing the disc material toward the spinal canal. First, let's talk about discal dural pain. This occurs when the intervertebral disc irritates the dura, often resulting in vague pain that is not limited to a single dermatome. Second, we have discal radicular pain. This is when a herniated disc presses on a nerve root, which leads to radiating pain down the leg, similar to sciatica. The symptoms often follow a dermatomal pattern, meaning the pain travels along a specific nerve path and may have relevant neurologic deficits. When this type of pain is persistent or severe, one treatment option we often consider is transforaminal epidural steroid injection, which delivers steroids right to the area around the affected nerve root. It helps reduce inflammation and can provide significant symptom relief. This procedure is usually performed under fluoroscopy or ultrasound guidance for accuracy and safety. Spinal stenosis means narrowing of the spinal canal or the intervertebral foramen. This puts pressure on the nerves and can cause pain, numbness, or weakness, especially when standing or walking. A classic presentation is neurogenic claudication, where patients experience leg discomfort or heaviness after walking a certain distance. Symptoms often improve when the patient leans forward or sits down, as this posture increases the space within the spinal canal and reduces nerve pressure. One serious complication we must always watch out for is cauda equina syndrome. This occurs when the lower nerve roots, the cauda equina, are compressed, often due to a large disc herniation or severe stenosis. Red flags include saddle anesthesia, urinary retention, bowel dysfunction, and bilateral leg weakness. this is a surgical emergency and requires immediate medical attention. The pain pattern of capsule and ligament problems is typically posture and movement related. We can try to stretch or pinch the structure based on anatomical knowledge to reproduce the symptoms and make a diagnosis accordingly. The facet capsule can be a source of pain, particularly when it becomes mechanically irritated, arthritic, or inflamed. In most cases, facet-related pain arises from mechanical stress, either tension or compression, placed on the capsule during movement. Pain may be provoked by movements that either converge or diverge the facet joints. In a divergent pattern, pain is usually related to tension and capsular stretching. It is often provoked by combined flexion and contralateral side bending, which opens up the joint and pulls on the capsule. These movements can lead to discomfort or pain on the affected side. In a convergent pattern, symptoms arise more from compression and increased intra-articular pressure, typically during extension and ipsilateral side bending, which closes down the joint on the painful side. These movements may provoke pain on the symptomatic side. Supraspinous and interspinous ligaments lie between and on top of the spinous processes. They can be irritated by repetitive strain or overuse, and they are often tender if you press on them directly. Vertebral fractures are often caused by trauma or weakened bones, like in osteoporosis. Lower back pain can also stem from acute muscle strain and chronic myofascial pain syndrome. Myofascial pain specifically refers to discomfort originating from trigger points in muscles or fascia. Non-mechanical causes. These conditions are often serious in nature and require thorough evaluation to ensure they are not missed. Conditions like ankylosing spondylitis fall into the inflammatory category. Patients often have morning stiffness that improves with activity. They may also have other signs like uveitis or family history. Sometimes, visceral referred pain from the kidneys, uterus, colon, or even the aorta can feel like back pain. This type of pain usually doesn't change with movement or posture. Infections like discitis, epidural abscess, or vertebral osteomyelitis are serious and need urgent care. Clues include fever, night pain, and elevated inflammatory markers. Cancer-related back pain, either from primary bone tumors or metastasis, should always be considered in patients with unexplained weight loss, night pain, older age, or a history of cancer. This type of pain usually doesn't improve with rest and may worsen over time. And finally, we can't forget psychological contributors like depression, anxiety, or chronic stress. Let's begin by observing the patient's overall posture. Examine the skin over the back and surrounding areas for any signs of infection or inflammation, such as redness or swelling. Also, keep an eye out for dermatological conditions that may relate to systemic diseases like psoriasis, which is associated with psoriatic arthritis, or shingles, which may cause dermatomal pain. Next, look for any signs of deformity or asymmetry. Assess the alignment of the lower back and lumbar lordosis. When screening for scoliosis, key features to look for including one shoulder sitting higher than the other, a scapula appearing more prominent, an uneven waist or hips, the head not centered over the pelvis. A useful tool for scoliosis screening is the Adams forward bend test. Ask the patient to bend forward at the waist, with feet together, knees straight, and arms relaxed downward. From behind, observe for a rib hump or asymmetry in the rib cage or lumbar region, which may indicate vertebral rotation, uneven spinal contour, or lateral deviation of the spine. Let's take a look at the Schober test, a quick and straightforward method to assess lumbar spine flexibility, especially helpful when screening for conditions like ankylosing spondylitis. Start by having the patient stand upright. To locate the L5 spinous process, first palpate the top of the iliac crests on both sides. The line connecting the iliac crests typically intersects the spine at the level of the L4 spinous process. From there, move one level down to identify the L5 spinous process, and draw a horizontal line across the lower back at that level. From this mark, measure and place a second line 10 centimeters above. Now, ask the patient to bend forward, as if trying to touch their toes. While they're in full flexion, remeasure the distance between the two marks again. In a healthy individual, the spine should lengthen as it flexes, and the distance between the two marks should increase significantly. A 5 centimeters increase is commonly considered the lower limit for normal lumbar mobility. However, a Taiwanese study screening healthy individuals revealed a significant age-related decline in mobility, as measured by the Schober test. Among males, the average increase decreased from 5 centimeters in the 21 to 30 age group to 3.1 centimeters in the 71 to 80 age group. For females, it dropped from 3.6 centimeters to 2.4 centimeters. These findings underscore the importance of interpreting lumbar flexibility based on age and sex. Additionally, perform the single-leg tiptoe standing test. Ask the patient to stand on one leg at a time. Then, keeping that same leg, ask them to raise up onto their tiptoes. This test assesses the strength of the L5 S1 myotomes. Next, observe the patient's gait. Watch for any signs of limping, asymmetry, or unusual movement patterns. One specific abnormality to note is foot drop, which may suggest a neurological issue such as L5 radiculopathy, peroneal nerve injury, or a central nervous system lesion like stroke or multiple sclerosis. Assess leg length discrepancy by measuring from the lower pole of ASIS to the medial malleolus on both sides with the patient. It's essential to consistently locate and measure from the same anatomical landmarks to ensure accuracy and reliability. Measure calf circumference 10 cm below the tibial tuberosity to assess for ipsilateral calf wasting. A difference of at least 1 cm compared to the opposite side may indicate L5 S1 radiculopathy. Let's begin by palpating the lumbar spine from L1 down to the sacrum, checking for tenderness, step-offs, or asymmetry. Next, ask the patient to slightly flex forward. Gently palpate along the midline to assess the spinous processes and the supraspinous and interspinous ligaments. Facet joints lie approximately 2 to 3 centimeters lateral to the midline. Palpate these areas by applying pressure over the paraspinal region, especially between L4 to S1, which is a common site for facet-related pain. Focal tenderness here may indicate facet arthropathy or paraspinal muscle strain. Next, perform the sacral thrust test. With the patient prone, apply an anteriorly directed force over the sacrum, using both hands to stress the sacroiliac joints. The test is positive if it reproduces sacroiliac pain. This test has a sensitivity of 63% and a specificity of 75% for diagnosing sacroiliac joint pathology. In younger patients, sacroiliitis should raise concern for underlying conditions such as ankylosing spondylitis. If sacroiliitis is suspected, a more detailed physical examination is warranted, though this is beyond the scope of the current video. Spine percussion is a straightforward physical examination method that can help assess the risk of serious back issues in patients. Typically, tapping on the thoracic and lumbar spine will cause pain in individuals with significant back conditions, like vertebral cancer, spinal infections, or fractures. This is because bone transmits vibrations effectively, which can irritate underlying problems. To perform the movement examination, have the patient perform backward bending, side bending, and forward bending. At the end of forward bending without pain, ask the patient to add neck flexion. Pain during any part may suggest a dural irritation. Neck flexion stretches the dural tube, and if it reproduces back or leg pain, it may indicate a positive dural sign. A painful arc refers to pain that occurs only during a specific portion of a movement. This is often observed when the spine flexes, causing a momentary bulge in the intervertebral disc. This bulging can increase pressure on nearby nerves or dural structures, leading to the sensation of pain during that particular part of the movement. This could suggest a problem like disc herniation, where inflammation or pressure affects the dura or adjacent nerve roots. When assessing lumbar nerve root function, each nerve root corresponds to a specific sensory area on the body. The key sensory point of T12 is at the midpoint of the inguinal ligament. L3 is at the medial femoral condyle above the knee. L2 is midway between T12 and L3. L1 is midway between T12 and L2. L4 is located directly over the medial malleolus. L5 is located on the dorsum of the foot at the third metatarsophalangeal joint. S1 is located on the lateral aspect of the calcaneus. S2 is located at the midpoint of the popliteal fossa. In addition to these, it's important to examine the saddle distribution, which refers to the area around the perineum, inner thighs, and buttocks, similar to the area that would be in contact with a horse's saddle. Sensory loss in this region may suggest cauda equina syndrome, a surgical emergency. To evaluate sensory function, light touch and the pinprick testing should be performed at each of these key points. The patient's face can serve as a reference for normal sensation, which ought to be intact in any spinal lesion. In addition to key sensory points for each nerve root, specific key muscles that correspond to specific nerve roots should also be tested, checking each side for strength and symmetry. L2 controls hip flexion. Ask them to keep the hip flexed at 90 degrees against resistance, assessing the iliopsoas muscle. L3 controls knee extension. Ask them to keep the knee flexed at 15 degrees against resistance, assessing the quadriceps femoris. L4 controls ankle dorsiflexion. Ask them to push their dorsum of the foot upward against resistance, assessing the tibialis anterior. L5 controls long toe extension. Ask the patient to push their big toe upward against resistance, testing extensor hallucis longus. S1 controls ankle plantar flexion. Test this by asking the patient to hold their foot pointed down against resistance, evaluating the gastrocnemius and soleus. Next, let's perform reflex testing, which helps us localize possible neurological lesions. The patellar reflex tests L4, the medial hamstring reflex tests L5, and the ankle jerk reflex checks S1. The straight leg raise test is one of the most widely used clinical tools for evaluating lumbosacral nerve root irritation, particularly involving the sciatic nerve. When leg pain radiates below the knee, especially between 30 degrees and 70 degrees of hip flexion, it often indicates irritation of the L5 or S1 nerve roots, most commonly due to a herniated disc. For diagnosing lumbosacral radiculopathy in patients with sciatica, the straight leg raise test has high sensitivity around 73 to 98%, but its specificity is lower, around 11 to 61%. This is because multiple anatomical structures are stretched during the test, including the sciatic nerve, hamstring muscles, gluteal or buttock structures, dura and lumbosacral nerve roots. That's why the following step-by-step method adds extra clinical value. By sequentially stressing different structures, we can more precisely localize the source of pain. Step 1. Test the unaffected side. First, with the patient lying supine, begin by raising the leg that isn't painful, keeping the knee fully extended. This helps the patient relax and gives you a baseline for hamstring flexibility, so tight muscles aren't mistaken for nerve pain. Step 2. Test the affected side. Raise the affected leg slowly. If symptoms appear, lower the leg slightly until the pain subsides. Step 3. At neck flexion, ask the patient to flex their neck by bringing the chin toward the chest. If this reproduces the pain, it suggests dural tension is involved because neck flexion pulls on the dural tube, reintroducing the symptoms. Step 4. Add ankle dorsiflexion. You can dorsiflex the ankle while the leg is elevated. This adds tension along the sciatic nerve, helping to reproduce radicular pain if the nerve is irritated. Step 5. Check for the buttock sign. If hip flexion is limited even when the knee is bent, or if the restriction seems to arise from the buttock or pelvis rather than the hamstring, this could be a red flag. It may indicate a more serious underlying cause, such as a tumor, abscess, or other space-occupying lesion at the buttock region. Now, let's go beyond the basic straight leg raise test and look at two specific findings that provide valuable diagnostic clues: the crossed straight leg raise test and the bilateral straight leg raise test. First up, the crossed straight leg raise test. When you raise one leg and the patient experiences pain on the opposite side, this is called a positive crossed straight leg raise test. It has a sensitivity of around 23 to 43%, but a much higher specificity, about 88 to 98%, for diagnosing lumbosacral radiculopathy in patients with sciatica. A positive result strongly suggests a central disc herniation, which is often associated with a poor prognosis. Next, let's talk about the bilateral straight leg raise test. A positive bilateral straight leg raise test means the patient experiences symptoms when each leg is raised separately. This finding may indicate a large central disc herniation and should be considered a potential red flag. The femoral nerve stretch test is used to assess for irritation or compression of the femoral nerve or the upper lumbar nerve roots. With the patient lying face down, the examiner flexes the knee and extends the hip. Pain in the anterior thigh is a positive result. This test has a sensitivity of 86% and a specificity of 64% for detecting lumbar spondylosis. Besides physical examination, be alert for red flags, suggesting serious conditions such as malignancy, infection, significant neurologic injury, and fracture. These red flags can include pain localized to the upper lumbar or lower thoracic spine, an uncommon sight for mechanical back pain and potentially suggestive of more serious pathology. Age-related concerns. Onset under 18 or over 55 years old with new or severe pain. History of trauma. History of cancer or unexplained weight loss. Unrelenting, non-mechanical pain, especially pain at night or not relieved by rest. Suspected inflammatory disease may present as unrelenting pain, but is typically relieved by activity. Other features include morning stiffness, peripheral joint symptoms, and involvement of the skin, eyes, gastrointestinal, or urinary systems. Signs of infection, fever, night sweats, recent systemic illness or immunocompromised status. Severe neurological deficits, cytoanesthesia, bowel or bladder dysfunction, progressive motor weakness, structural deformity, or severe limitation in movement. If any of these red flags are present, further investigation or referral is necessary. Before we finish, let's quickly review with a few questions. Which clinical finding during the straight leg raise test best supports the diagnosis of lumbosacral radiculopathy due to a herniated disc? A. Pain localized to the posterior thigh during passive leg raise. B. Pain radiating below the knee between 30 degrees and 70 degrees of hip flexion. C. No pain with passive leg raise, but discomfort during active leg raise. D. Hip flexion restricted even when the knee is bent. The answer is B. Pain radiating below the knee between 30 degrees and 70 degrees of hip flexion. This range is sensitive for detecting L5 or S1 nerve root irritation, typically due to a herniated disc. A. Pain localized to the posterior thigh during passive leg raise typically reflects hamstring tightness, which can also be seen in the unaffected side. C. Discomfort during active leg raise suggests that the problem may stem from contractile structures such as muscle, tendon, or space-occupying lesions being pinched by muscle. D. Hip flexion restricted even when the knee is bent suggests the buttock sign, which may point to a space-occupying lesion in the buttock or pelvis. Which test can we perform when inflammatory back pain such as ankylosing spondylitis is suspected? A. Straight leg raise test. B. Cross straight leg raise test. C. Schober test. D. Femoral nerve stretch test. The answer is C. Schober test. Here's a mnemonic for inflammatory back pain, eye pain. I. Insidious onset. P. Pain at night. A. Age at onset, under 40. I. Improvement with exercise. N. No improvement with rest. Which of the following are considered red flag signs that may suggest a serious condition? Select all that apply. A. Fever. B. History of minor sprains. C. Unexplained weight loss. D. High energy trauma. E. Gradual onset of mild, localized pain. The answer is A, C, and D. You are correct.